Yeah, so this child doesn't add around 3 scans within a time frame of 3 weeks. This is the second scan, I think, after a couple of days of clinical presentation. So we have diffusion panel on top, and you can appreciate there is a small focus of diffusion in the right trigonal region. But the major findings are in the posterior fossa, demonstrating subacute infarcts in the bilateral cerebral hemispheres and also the vermis. And as you can see, that is causing compression on the fourth ventricle, resulting in some obstruction and hydrocephalus with periventricular seepage of the CSF. There's also inferior tonsillar herniation and a degree of mild basilar impression. So it's acquired CRE1 deformity with bilateral posterior circulation strokes, resulting in mild degree obstructive hydrocephalus. This is the angio, and on the MIP images, you can appreciate that the left vertebral artery is not visualized. The pica on the right also was not visualized. The superior cerebral artery, which is this on the left side, is not visualized on the right. And also the ICA is not visualized on the right. I'll just play the source images. And as you can see, the right vertebral artery is visualized, whereas the left vertebral artery is not visualized. The distal segment is faintly visualized, forming the basilar artery. The bilateral posterior cerebral arteries demonstrate a normal appearance. So it's a primarily posterior circulation stroke presenting with secondary compressive changes. The patient underwent decompression, and this is after 2 weeks. As you can see, there are chronic ischemic changes in the posterior fossa, but they have this new change along the right temporoccipital region, which was not there in the previous study, and also in the posterior cingulate region. The CRE has somewhat improved, but yeah, these are the new changes which were seen post decompression. And then the clinical question was, Dr. Lokesh, if this is arteriopathy or if this is possible of a moya-moya? Is that the question?
One of the post bony compression, any abnormalities that we can look at this point in acute period. Okay. I think we had a CT done as well for this child initially.
Yeah, the CT showed mild, I didn't put up, but it had mild basilar impression. But that has been relieved or at least improved on the post-operative scan.
Oh, okay.
So I think the posterior, the right PCA territory infarct could be maybe during operation or something related to the intraoperative period.
Intraoperative, they did just a decompression and put in a reservoir.
But there are no collaterals to say something like a moya-moya, and it's too early to say it's a moya-moya. Thinking arteriopathy as a possibility with the CVG abnormality on the initial scan. Dissection obviously cannot be ruled out.
For us, the clinical dilemma was he initially came with a unilateral stroke, and we had anticipated that there might be significant increasing edema within 24 hours. It worsened rapidly. That's when the second scan was done, which showed bilateral infarcts and brainstem compression with respiratory depression. So the dilemma for us was if we intervene and salvage the breathing now, what is going to be the sort of long-term survival and the quality of life. So in fact, we had to do a tracheostomy to get him out because he developed bad neurogenic stridor after extubation. So we had to send him home on tracheostomy, although he was breathing well on his own, with minimal responsiveness still, but the motor responses were improving. So the dilemma clinically during the acute period is always this, whether we are doing a good job of saving the life or we are going to give the family a very disabled child. So I think it's very challenging to answer just based on the imaging. I'm not sure in the group anybody has a better way of guiding this acute decision making in this situation.
No, not particularly. I don't think there's anything to add here. It's a very sad case.
Yeah, so almost 20 days into the acute illness, 25 days, he went home on a tracheostomy, not able to still recognize, but anti-gravity movements were seen. And he was not requiring any oxygen or any ventilatory support. That's what we could do. We'll have to just see what's going to be in a year's time.
Yeah, I think last time we were discussing that cerebellar infarcts don't have a bad prognosis overall, but here in this case, the brainstem has a lot of scarring.
Yeah, true.
I missed the age of the patient.
6, I think. 6-year-old.
Yeah.
Thank you.
Yeah. Thank you. I think we can go on to the next case.
Okay. Case 2 is from Professor Rostasi, was shared to Professor Balthazar, who was kind enough to share the case for presenting today. So it's a child with gait difficulties for around 6 years, with loss of ambulation for around 10 years, had progressive polyneuropathy. The nerve conduction velocity was not measurable at the age of 16, and the MRI was done at the age of 16 years. Just more detailed history. The family was from Syria. There's no family history for neurological disorders. Apart from the index case, there are several other siblings which are healthy. His early development was normal. Onset of gait difficulties at around 6 years. Loss of ambulation at 10 years. Progressive polyneuropathy, including marked distal muscle wasting and weakness with scoliosis. Examination at the age of 16 years demonstrated areophexia. Cognition, vision, and hearing was normal. Would you want to add anything, Argan? The clinical presentation?
No, this was an electronic discussion. I have not seen the patient.
Okay. So I'll move on to the MR images. We have the T2 axials, and we have these periventricular confluent abnormalities in the bilateral cerebral hemispheres, also involving the middle thalami, the central white matter. The brainstem also demonstrates abnormality. There is cerebellar atrophy, and if you appreciate the dentate nuclei, the hilus of the dentate nucleus demonstrates signal changes, and also the cerebellar white matter is abnormal. So supratentorially, the corpus, if you see the corpus callosum is relatively spared. I'll probably show on the, so the striatal images, again, you can see that the corpus callosum is spared. There is a volume loss of the midbrain, the medulla, and also the visualized cervical cord, and also atrophy of the cerebellum with the white matter changes in the bilateral dentate nuclei and the cerebellar white matter. To summarize the finding, there is a cerebral leukoencephalopathy with sparing of the corpus callosum and the subcortical white matter. Signal abnormalities in the brainstem and the cerebellum with cerebellar atrophy. Dentate nucleus changes were seen predominantly in the hilus and the peridentate region, and there is cervical cord atrophy. At this stage, I would like to invite Dr. Meenal Garg, who also had presented a similar case and had shown this case to Dr. Balthazar in 2016. So after I think Dr. Balthazar saw this case, he reminded me of Dr. Meenal Garg's case. So I'd like to invite her to present her case.
Thank you, Dr. Nihaal.
Yes.
So this child, she was an 11-year-old girl. She was the second of twins and born to third-degree consanguineous parents. So she had history of prematurity. She was low birth weight, and she had a prolonged NICU stay of around a month. And she had global developmental delay right from the beginning, motor more than mental delay. She had a few seizures at around 5 years of age and was given only a single drug for them, and these seizures were controlled. And then she developed ataxia and motor difficulties after 5 years of age, which were slowly progressive. So she came to us at 11 years, and at this time on examination, she had microcephaly, she had short stature, she was underweight, and in motor difficulties, she was only able to sit with support. So she had dry skin, woolly hair, and she was dysmorphic. She had triangular faces, very arched eyebrows, retrognathia. Positive findings on examination were nystagmus, fundus was normal. She had scoliosis. PAR was around, she had anti-gravity movements in all of her limbs. Deep tendon reflexes were absent, and she also had cerebellar signs. So these were the initial investigations. Eye examination showed only blepharitis, normal fundus. Routine metabolic tests, including TMS, GCMS, and CSF, were normal. We had done plasma VLCFA analysis, which was also normal. Hair shaft analysis was also normal. And NCV showed a progressive sensory motor axonal neuropathy.
So at this stage, I'll probably take over with the MRI findings. And we have the flare images on top. The axial flare images again have demonstrate these periventricular hyperintensities with related sparing of the subcortical regions. And on the coronal T2s in the posterior fossa, again, you can appreciate the similar posterior fossa findings as seen in the case from Dr. Bolthauser. Again, there is hyperintensity of the hilus. The dentate nucleus itself is slightly dark. Cerebellar white matter again demonstrates these high signal changes. The axial images again, the flare images, you can appreciate the typical pattern of appearance of the dentate nuclei and the cerebellar white matter. The volume is relatively spared as compared to the index case. CT brain, the thalama appears slightly bright, or some hyperdensities are seen. No abnormalities on diffusion or ADC. Spectroscopy also, I could not appreciate any significant changes. So going back to Dr. Bolthauser's case, Aigen, do you want to confirm the diagnosis?
So yes, on genetic analysis in our patient, we found.
Okay, Dr. Meena, this is Dr. Bolthauser, but anyway, Dr. Bolthauser's case also turned out to be positive for, yeah.
I have to confess, when I've seen these MR, I have no diagnostic clue for certain. And then in retrospect, they told me that the child had abnormal hair, as we have seen in the case of Dr. Garg. So I think this is an important clinical information. And they said, what you see depends on how you look. So this a progressive condition with this type of hair is a giant axonal neuropathy until proven otherwise. And what I think is important, that all four levels, so to say, are involved: cerebral, cerebellar, spinal cord, and peripheral nerves. And this is kind of a unique constellation, I think.
Back to you, Dr. Garg. This was actually published in a case series of around 3 patients. So Dr. Garg, if you want to summarize the findings.
So actually, we had also initially missed the diagnosis in this patient. We had considered peroxisomal disorders, and we had also thought about cocaine syndrome. That's why we did the shaft analysis and everything. On CT, actually, there were very small calcifications, which are probably not very evident in this scan. So that's why we had thought of that. So when I discussed this case at ICNC, that's when we got this suggestion of doing the GAN gene. And after that, we had confirmed the analysis. So all of the patients in this series, they presented with a similar clinical picture, and the hair you can see are evident in all of them.
And the MR imaging finding are also pretty similar in all the 3 areas. The cerebellar changes and the supratentorial Lucan circle type changes with sparing of the corpus callosum. Again, do you want to probably summarize the?
I have only seen one patient a long time ago, so I have some kind of interest for historic reasons. You see, in 1977, I was asked to publish this case. I mean, the diagnosis was made by Albert Bischoff, a neuropathologist. This was the case number 5 in the world. And the first case was reported in 1972 on a sural nerve biopsy. And in terms of this morphological finding was called giant axonal neuropathy. But the post-mortem analysis on our patient showed that this is a generalized disorder. So in a way, I mean, this name is now fixed, but this name is a misnomer. This is a generalized disorder of microstructure in the brain. And most patients, but there are exceptions, have abnormal hair. There is a Tunisian variant I've read now, with normal hair and slightly different course, I understand, and dominant inheritance. So I think on the whole, looking at the history, the course, the hair, the image, the diagnosis is not difficult. Of course, you diagnose what you know. So this is kind of a reminder.
Right. Thank you, again, and thank you, Dr. Mino. So I think there are a total of 45 individuals from these recent literature review with giant axonal neuropathy. And just a note on the imaging differentials with the dentate nucleus abnormalities. The more confluent abnormalities of dentate nucleus can be seen in glutaric acidurias, mitochondrial disorders, L2-hydroxyglutaric aciduria. Sometimes NF1 can be present in a symmetrical manner. The heterogeneous appearance of the dentate can be seen in congenital muscular dystrophy. This is a mucin negative CMD, LCH, lysosomal disorders such as Krabbe's, CTX, and this is the Eigen's case of giant axonal neuropathy. So here are the differentials for, at least on the imaging basis. If anyone wants to add anything further to it, Dr. Mankad or Dr. Lokesh.
Not particularly. I think I was just thinking, looking at it, the next time I see a case, I think the clinical phenotype is also quite strong, but they're so rare. I was just thinking, how will we actually suggest that as a possible diagnosis to be screened for? These were my thoughts.
The combination of cerebral and cerebellar white matter plus dentate nucleus may point to that direction.
Yeah. Is this screened for automatically in a mitochondrial genomic, or when we suggest? We have to suggest it in our report, isn't it, for it to be tested, I think.
Nihaal, can you show the next slide again? Maybe, I don't know whether we have time. I mean, in papers about abnormalities of the dentate, you see a long list, but the list includes cases where the hilus is abnormal, the whole dentate is abnormal, the cerebellar peridentate is abnormal, and I wonder whether one could cut it down a little bit more in terms of logic, which anatomical structures are mainly involved.
Exactly, you took the words out of my mouth there.
You understand my point?
Yeah, completely. I think the special phenotyping of this has not been done in terms of dentate. We just call it dentate signal changes without really looking into the hilus or what's happening or the configuration of the signal. So probably something for Nihaal to pick up as a piece of research, which will add value.
Some homework, yeah.
Okay. That's a big homework. We can have an aside conversation about this, Nihaal, later on.
Yeah. Anything else to add, Dr. Lokesh, Dr. Ramesh, or Dr. Kavita?
Hi, good evening, everyone. Nothing more to add. Please go ahead.
All right. Thank you. Moving on to our next case, Keithig, if you're here. Is Keithig there? Okay, I'll go ahead with the case. It's a newborn child, full term delivery, normal birth weight, and died immediately after birth. No history of perinatal asphyxia. Was born to a third-degree consanguineous couple. There was history of neonatal death in the sibling. The cause was unknown. Antenatally, on the ultrasound, the child had bilateral ventriculomegaly at 26 weeks gestation. There was neonatal seizures on day 1 and day 5 of life. No documented hypoglycemia. There was significant neonatal encephalopathy. Child was hypotonic, had subtle facial dysmorphism in the form of broad forehead, telecanthus, and there was no acidosis. The CSF analysis was normal. Moving on to the MR images. I think one of the fellows can take it. Dashrath, do you want to take it? Okay, I'll go ahead. So you can see there are bilateral abnormalities in the perisylvian region extending up to the frontal and parietal lobes. So there is perisylvian polymicrogyria, subependymal cysts along the bilateral lateral ventricles, some abnormal white matter changes in the cerebral white matter. A zoomed in picture, you can better appreciate the subependymal cysts. The coronals again better appreciate the polymicrogyric appearance. There's also hypoplasia of the cerebellum. The brainstem, the horns also demonstrate slight hypoplastic appearance. On the diffusion weighted scans, you can appreciate this extensive posterior to anterior gradient changes of cytotoxic or restricted diffusion, predominantly involving the cortex, and also some areas of the subcortical white matter. This actually reminded us of a case which was scanned a few months back. This is from Dr. Ramesh. Again, similar malformative changes, similar changes of paraventricular or subependymal cysts, and also areas of restricted diffusion in the posterior predominant aspect. This case was a child with hypoglycemia, whereas the index case, the presentation at least mentions that there is no documented hypoglycemia, but I would think the changes are probably consistent with hypoglycemic brain injury with or without hypoxic injury. The malformation and the subependymal cysts would probably point out to a diagnosis of paroxysmal disorders such as Zellweger syndrome. This is just the example of how extensive the hypoglycemic brain injury can be. It can extend up to the frontal regions, predominantly involving the cortex and subcortical regions. So clinically, just the question was, there was no documented hypoglycemia. Can the imaging findings be possible, or have we missed something in the history?
Can you go to the first slide? Is there any facial abnormalities? I may have missed it.
Yeah, there is. They mention it as broad forehead and telecanthus with subtle facial dysmorphism.
So, I mean, this is if you lead broad forehead, telecanthus, facial dysmorphism, this sounds for me like Zellweger syndrome, which of course is a paroxysmal condition, which would explain at least the hypotonia, the neonatal seizures, and the MR, apart from the hypoglycemic aspect.
Yeah.
Did you all ever confirm a paroxysmal disorder for the other case, which also had hypoglycemia and the malformation?
I think this was a confirmed case because this was done in April, if I'm not sure.
But confirmed.
Some patients with Zellweger syndrome or with these very early biogenesis disorder, they have abnormal calcification around the knee. Did you do an X-ray of the knee?
No, we don't have this. I think Kirti is not there, so probably I'll just check with her.
Is there a connection? Is there a theoretical connection when children are born with this inborn error of metabolism until proven otherwise? This is Zellweger's, right? And the fact that they actually are not fed well, and this is too much to have so much hypoglycemic kind of injury in the context of another malformation. I wonder what the kid was.
Very unusual, Kish, to have this extensive hypoglycemia. There are many other children with Zellweger's who don't have any of these changes. Not sure, as I said, whether they had poor suck and then not noticed and had seizures. But day 1 seizures are very unusual for hypoglycemia. Generally, day 3 seizures are very classical for neonatal hypoglycemic brain injury. But here it was day 1 and day 5 seizures. That day 1 generally are hypoxic seizures, but the pattern is not very hypoxic.
I think we will have to think a little about this case because they're not just the posterior changes, there are anterior changes as well, which could all be hypoglycemia related. But
I don't think all are hypoglycemia. Maybe there's a component of hypoxia.
Yeah, exactly. Maybe the mother was not feeding this child and they were having subclinical seizures or something. Seems to be but hypoglycemia can affect the whole brain. It doesn't have to be posterior only. It's a mimic.
Yeah.
And if this was hypoxia, then we would think about a sustained low-level hypoxia, right, with the parasagittal infarctions.
Yeah. So
very
it is
low
a
fatty acid being measured.
event or is a double trouble? Sorry, I didn't get it.
Very low, very long chain fatty acids are being measured, or did I miss the point?
No, this baby was scanned, I think 2 days back. Exactly scanned at another city and was sent for another opinion. And I don't think we have the diagnosis or any lab investigation yet.
So can I add something?
Yeah, please.
Yeah, so paroxysmal disorders can have hyperinsulinism. So we had 2 patients in the neonatal period. One of them had a high insulin level with low sugars. So we did search at the time, and because it was unusual to have 2 illnesses. And often in metabolic disorders, hyperinsulinism causes hypoglycemia. So that's one aspect which contributes to the dual pathology.
I think Kirti is there, but she's not able to speak. I'll just probably get the IT team to get back. Probably get back to this case after the discussion of all the cases. Vishnu, if you can hear me, can you make Kirti as the panelist? Okay, I'll go on to the next case and maybe we'll come back to this after all the cases. Case 4 is from Dr. Ramesh. Surbi, are you here? Okay, so it's an 8-year-old boy with refractory right focal non-motor seizures. Started at the age of 6 years. There's mild cognitive delay. Birth history of the child is the second child of a twin pregnancy. It's full term with no birth asphyxia. There's an NICU stay for 2 days. There's borderline hypoglycemia on day 3. No neonatal seizures or encephalopathy. The EEG demonstrated right hemispheric discharges. And the clinical question was, are the imaging findings a sequelae of hypotensive or hypoxic injury? Though there is no documented hypoxia, the twin pregnancy was probably a risk factor which they wanted to rule out. We have external films, and T2 and the flares, and you can see maybe better on the flares. There are these multifocal areas, patchy areas of hyperintensities, predominantly in the right cerebral white matter in the subcortical regions, and also in the posterior periventricular regions. Some abnormalities also demonstrated on the left posterior periventricular region. Also, the cortex is also involved in the right frontal and parietal region. If you can appreciate that there is some degree of asymmetrical prominence of the folia on the right frontal perisylvian region as compared to the left, probably some degree of asymmetrical atrophy of the right frontal region and perisylvian region as compared to the left side. Posterior fossa, I could not appreciate any abnormal signal changes. The basal ganglia and thalami also did not demonstrate any significant abnormalities. Coronal images, again, similar changes which were seen on the axials. Predominant involvement of the right cerebral white matter and also the gray matter involving the cortex. Some asymmetrical atrophy of the frontal regions. So I would not, I don't know what Dr. Mankad or anyone else would think, but I would not think that these are changes related to hypoxia or hypotension, at least in the neonatal age group. Whether we're dealing with a demyelination or an infection was the doubt on the images. And the atrophy, if patient has right focal epilepsy, if they are related to the epileptic discharges or not, was the question.
Just sorry to join late. I just rejoined as panelist. I was not able to speak earlier. So this child has clinical seizures which are corresponding with that right parietal lesion. Just around the central sulcus there is a lesion, right? Centroparietal. So the EEG changes and clinical seizures are corroborating with that particular lesion. But overall, I was not sure what is this pattern of injury suggesting. Is it a hypoxic injury, global hypoperfusion injury? That was the main question. Clinically, there is no acute sentinel event now, but he had some neonatal complications requiring NICU admission.
Can I ask, this was a second of twin. What about the other twin? Do we know, are these zygotic twins? Twins have high prevalence of malformation, disruption, and so on. So this could be related to twin situation. Just to
yeah, the other twin is a girl and she's healthy. Is that what you're asking?
Yeah.
The twin-to-twin transfusion and those sort of things occur, no?
They occur, but these are not pretty typical of a hypoxic injury. They're pretty asymmetrical.
Okay. Is there diffusion restriction?
I don't have diffusion in this.
Actually,
it's a late scan. It's at the age of 8 years.
This is a late scan. It was not in the acute period. Because of epilepsy, we did the scan. There is no restricted diffusion.
I don't think this is a cortical dysplasia. If that is the question, Dr. Ramesh, it looks like more of a
that's
normal signal change.
It's scarring, and it's mostly right hemisphere.
Yeah,
I think line on the left hemisphere is actually an artifact on one of the sequences. And I think the twin transfusion theory works for this, even though it is unilateral. And infection would be unusual to be on one side only. So this, but not a cortical dysplasia for sure.
So hypoperfusion can affect predominantly one hemisphere. Is that right? Hypoperfusion injury.
It is quite unusual to do that, but any embolic phenomenon from the maternal fetal placental unit could do that, as well as the fact that this could still be infection, but it's unusual to again have it all on one side. Because I thought, Nihaal, you can correct me, the left side is totally normal, isn't it, on right-sided images, or do you have some there as well?
Yeah, I think in the frontal there were some white matter changes, if I'm not wrong.
On the left as well? I can't see that.
If this is functioning or not, I'm not sure, but
either way, acquired biotic injury and ischemic or infective in nature. And I don't think you need to go around looking for genetic basis either on these cases.
Okay. Only those cortical changes were little unusual for any form of hypoxic or hypoperfusion injury. The frontal opercular region and the central region. Okay.
Okay. Yeah, the T1s, you can see the cortex, it's not malformed, it's actually gliotic or presence of emulation as well. Yeah, post-acquired injury would be the hypothesis as Dr. Mankaraji.
Okay, some old injury, and that's it.
Yeah, we don't have the diffusion, but I don't think the presentation is acute, so
yeah, it was normal. There were no diffusion changes.
Okay. Moving on to the next case. Dashath, are you available? Unmuted. Okay, I'll go ahead with the case. It's a case with a child with acute febrile illness, had extrapyramidal syndrome in the form of rigidity, postural tremors, hypomimia, and pseudobulbar dysfunction. Japanese encephalitis serology was negative and lactate was normal. Again, external scans, and you can see the predominant changes in the dorsal striatum, which is edematous. On the T2 and the flares, there is some degree of cerebral atrophy, but the primary changes are in the dorsal striatum. Posterior fossa cannot appreciate any abnormality. Brainstem is appearing normal. Thalami also normal. No malformations, no white matter changes. Diffusion, there is some bright signals on the DWI, but they don't correspond with the low signal on the ADC. So there's a facilitated or a slightly mixed partner diffusion, but predominantly it is a slightly subacute stage or old stage. But edematous change in the dorsal striatum and some degree of volume loss in the cerebral and cerebellar hemispheres on both sides. Sagittal images, there's mild thinning of the corpus callosum, no signal abnormalities in the white matter. Post contrast images, no contrast enhancement. I think the question was clinically it's an anti-D2R antibody or a biotin time and responsive disease disorder. Lokesh,
Now we had clinical differentials where because hyperacute onset, we thought of viral encephalitis as a primary differential, especially something like JER dengue associated encephalitis. But there are no restricted diffusion. This is a hyperacute scan. I think it was done within 48 hours after the symptom onset. So that's why our differentials, in the absence of restricted diffusion, it was restricted to either demyelinating or other antibody-associated diseases. So he got better quite quickly. CSF was normal, JE antibodies were negative. There are no features of dengue encephalitis. So that's why we didn't have other clues for where to go forward.
Just to say, I'm not sure if these are right signal change in the cortex. If you see in the bottom panel, the right front bilateral frontal over here is the artifactular real. The medial thalami are spared. I don't think any abnormalities in the mammillary bodies, but I would consider these possible differentials infectious and also, as you say, genetic disorders such as Simon responsive and any particular clinical presentation for the anti-D2R antibody, Dr. Lokesh? Or is it too soon to categorize them?
They have very varied presentations. Some of them are very chronic presentations are seen. They can present with non-specific movement disorders, slowly progressing over a period of months as well, without not too much of the changes on the MRI. Whereas you can have acute presentations like this with basal ganglia swelling and anti-DR2 antibodies. We tried confirming in 2 cases, but we couldn't get a result. We had sent the samples to Australia, but we couldn't get a results later on. But those are the presentations reported, not very specific for one type. Both acute and chronic are noted.
Just a related question. I just had a case yesterday. This child had confirmed dengue, but has only bilateral globi-pallidi lesions and some periventricular white matter lesions. Is that consistent with dengue? Only GP involvement, sparing caudate and putamen.
Yeah. No, but no hemorrhage. Hemorrhage would have been more specific. But I think, you can.
Okay. Yeah, I'll include it in the next session. It was yesterday. Yeah.
Dr. Lokesh, did you give any immunomodulators to this child?
Yeah. We gave immunomodulators. They had already received 1 gram of IVIG from outside. We completed the course, and then actually he got quickly better with his tremors and the motor abnormalities, and he was able to walk home actually within a short period of 5 days.
Okay, thank you.
So no other comments. I'll probably move on to the next case. Next case is from Dr. Ramesh, which was an 8-year-old child with global developmental delay, presented with febrile and afebrile seizures, and was operated for squint. Had a query of cerebellar signs. Anything to add, Dr. Ramesh? This is the case with malformation.
Doubtful cerebellar signs. Yeah. No, nothing much in the clinical detail.
Okay. So here we have the MR images, the T2 axial images on top, and I can appreciate that the bilateral frontoparietal regions are severely malformed. This is demonstrating a cobblestone type malformation. Almost the entire cerebral hemisphere cortex is abnormal. There's a slight abnormality of the ventricles. The basal ganglia and thalami demonstrate normal appearance. There are some subcortical hyperintensities. These linear hyperintensities adjacent to the cortical malformation. In the zoomed in images of the posterior fossa, you can appreciate these tiny microcerebellar cysts, especially on the right cerebellar hemisphere. The corpus callosum is dysplastic. The brainstem is also abnormal and hypoplastic. The vermis also is abnormal. Thin slice T1 weighted images, again, you can appreciate the extensively malformed cortex and also the subcortical cystic changes. Cerebellum, these are actually subcortical subpial cysts. Over here.
I think one of the registrars should attempt the diagnosis, right, and see what are the differences.
Okay. The angio was normal.
Yeah.
So yeah.
The presence
So,
of
Surbhi? Yeah, that's right. Yeah.
In the presence of and the cerebellar cyst and brainstem hypoplasia, congenital muscular dystrophy should be thought of.
Okay. Anything else? Okay. Yeah, Nihaal.
Okay. So it's actually cobblestone malformations. They slightly differ from polymicrogyria, whereas the gap is slightly larger than the polymicrogyric cortex, resulting in this typical appearance, this jagged type appearance of the cortex with these intracortical and subcortical hyperintensities. These are the genetic abnormalities associated with this disorder, and the primary, the differential, as Dasharat has said, is the congenital muscular dystrophies, but other genes which need to be considered are the collagen-related disorders, LAMA2 mutations, GPR56 or the ADGRG1 mutations, LAMB1, LAMC3, and TMTCR3 are also differentials for this presentation. These are just cases from literature of collagen-related disorders and the GPR56-related disorders. Again, you see this typical appearance of the cortex in the form of cobblestone appearance with cerebellar microcysts, dysplastic corpus callosum, abnormal hypoplastic brainstem. Collagen-related disorders can also have arterial abnormalities in form of aneurysm. And yeah, so based on the imaging findings, at least we would consider these as the possible differentials. If Dr. Mankad wants to add anything, because he was on this paper of which defined the malformations of cortical development recently.
No, nothing to add. I think that was pretty comprehensive. Do you have the answer for this particular case, or you're still screening them?
No, this was just done 2 weeks back.
Yeah, just recent one. Not yet confirmed.
Ramesh, anything on the creatine kinase, the phosphokinase, I mean?
No, actually, it was very difficult to convince the parents for any further tests because child had just infrequent seizures, easily controlled, and mild developmental delay. So probably in the follow-up visits, we'll work him up.
It's incredible, right, Eugen? You will agree that with such malformations, sometimes the extent of seizure activity is quite low, actually.
Yes, surprising. Yeah.
It is quite well preserved, otherwise developmentally as well.
In this case, one of the things that first came to my mind was indeed GPR56. They have abnormal visual problems as well, right? Does this kid have any?
He was operated for squint.
Squint, okay.
No other ocular abnormalities, but only squint was there.
Okay.
Okay. Next case, Ramani, if you're there, you want to present it? Or Dr. Kavita? Or should I go ahead? Okay, I'll go ahead. So it's a 7-year-old girl.
So this was a...
Okay, yeah.
Yeah, no problem.
Please go ahead.
So this was a 7-year-old girl who came to us for complaining of vomitings since 1 month, going off and on. And since last 3 days, she had a severe headache. But otherwise, on examination, she did have neck stiffness and signs of raised ICP in the form of hypertension and mild bradycardia. And on examination, she had a little bit phenotype of Fanconi's, very pinched kind of nose, microcephalic and capillary spots. But otherwise, there was no papilledema. I mean, no chronic signs of raised ICP as such. When we investigated her, her ESR was 64. Firstly, we did not do a CSF and just managed with all the raised ICP measures, managed all 3%, etc. And then maybe we can first discuss the MRI and then come back to the investigations. The only thing which was positive was COVID antibodies were strongly positive in high titers, and the D dimer was also quite high. Yeah.
So we have the MR images, non-contrast flare axials on top, and you can appreciate that there are these nodular lesions. The right frontal region demonstrates almost a conglomerate appearance with significant perilesion edema. There are also some tiny lesions in the left posterior periventricular region. Doubtful abnormality on the right cerebellar hemisphere, but it is hyperintense. The diffusion changes. There's some area of central areas of restricted diffusion, especially in the right frontal lesion and also in the left posterior periventricular lesion. The GREs demonstrated these areas of blooming in the right frontal region and also in the left periventricular region. I think I'll probably go to the CT first. Yeah, non-contrast CTs. We have these multiple small areas of calcifications which correspond with the low signals on the GRE. Can also be seen in the right cerebellar hemisphere. Going back to the MR, the post-contrast images, you have these ill-defined areas of ring-like enhancement in the right frontal region. The left posterior lesions also demonstrate ring-like enhancement. There are some internal projections in the right frontal lobe lesion, and in the right cerebellum demonstrates some nodular foci of enhancement. Spectroscopy was done in the right frontal region and demonstrated a large lipid lactate peak. Rest of the peaks, I cannot find any diagnostic significance. Unfortunately, I did not look into this case really, but I would think probably an infection, at least of the lesions. They are probably abscesses or fungal lesions, not able to bind the calcifications and the lesions. The calcification appear to be more of a chronic abnormality if there is any history of congenital infections or tuberculosis, prior tuberculosis, Dr. Kavita?
No prior history of tuberculosis. Mother had tuberculosis 20 years back, and this girl is only 7 years old. So there is no immediate history of any contact, at least in the child's lifetime. And only so with this CT showing the midline shift and everything, we waited for some time till the acute ICP or settled down, and then we did a CSF, which actually came to be normal, including the gene expert for TB-PCR and all. Though on the basis of MRS and very thick-walled, ragged kind of appearance, we thought of tuberculomas as our first diagnosis. So I'd like to know the expert's opinion. What do you think, Dr. Eugen and Dr. Kshitij?
I can go first if you want. So on the background of multiple calcific foci, you have this lesion. And the obvious thing to exclude would have been a large tuberculoma, right? How confidently has it been excluded? I mean, would you go as far as looking at quantiferons or, other things as well?
So no, because we didn't get anything much in the CSF, we did not do that because gene expert is supposed to be quite sensitive for tubercle antigen, so which we didn't find. So we actually then went ahead with the biopsy, which I'll tell later once the discussion is over.
I think it is a deep.
The gene expert. Yeah, sorry.
Yeah, please go.
Yeah, no, the gene expert sensitivity for tubercular meningitis as such, where you have a lot of cells, is only around sort of 35 to 50%. So, but tuberculoma, which is very localized and duocellular, even much less sensitivity for the gene expert on the tuberculomas, unless you are sending the tissue.
That's what. Yeah. Agreed, because we didn't have much of proteins also high, so there was not much of meningeal involvement, so we were not expecting the gene expert to be positive.
The cerebellar lesions seem to be distant anatomically. So, any infiltrative disorders radiologically?
You mean something like lymphoma and leukemia, things like that?
Yeah, histiocytosis. Yeah.
Which of those would calcify unless we're dealing with two pathologies?
Not for the calcifications. The even cerebellar lesions are also showing enhancement. They're also probably
but
acute.
there is a calcification even inside these lesions. If you see those, Dr. Nihaal, even inside these lesions also there is calcification.
Exactly.
Inside that big one also.
Yeah.
Could this be congenital PMD? I mean, the child is microcephalic.
Yes. And as I said, we were also suspecting Fanconi's anemia on the basis of the child had thrombocytopenia. One of the previous CBC's hemograms that we could get hold of 2 years back also showed a platelets of 50 to 60,000. So there was a chronic thrombocytopenia, though there was not any significant anemia. And the phenotype, as said, little short stature, microcephaly, with a little crowded face, look like a Fanconi anemia, though we have not been able to investigate that angle further. So there may be certain degree of immune dysfunction because of the underlying Fanconi anemia as well. The surprising thing was there was not much fever. So for 1 month she had just off and on vomitings, and then this acute thing happened since last 3 days only. This kind of presentation we are getting very frequently now in the COVID times. Something chronic is going on, which is even giving rise to calcifications, and then they're just decompensating with the maybe some second hit kind of thing. So I would just
would you consider fungal abscess possibility?
Before you go, how would you read that spectroscopy?
The spectroscopy, a large lipid latate peak, reduced NA, creatine is reduced.
Does the lipid lactate
at 3 points? At 3.6 is a large peak, but I don't know if this is a short. I'm assuming it's a short T, and that could be a possible Trehalose peak.
Yeah. So basically, showing a lot of necrosis, isn't it?
Yeah.
Essentially,
so my question was: are these internal projections of a possible fungal lesion on the contrast, at least the larger lesion, which can be associated with?
So no fever, relatively well, and you have a COVID status that's positive with multiple calcific lesions in the brain. I mean, I generally look for unifying diagnosis. You can have more than one possibility, but clearly we have an answer here, so we should proceed to that. I mean, I don't think I can offer any more differentials at this point.
Yeah, so
yes,
a biopsy,
as well.
Yeah, a biopsy was done, and it did show caseating necrosis, which is suggestive of tuberculosis. But we are still awaiting the final report of the histopathology. So I think it's almost 99% that it's tuberculosis or tuberculoma. But what was unusual in this child was that for so long she might be harboring these and tuberculomas which have healed by themselves with calcifications and without any fever, and probably there is interplay of the host and the this immunity, and right now with this COVID thing coming in, maybe there is a decompensation of that immune response, and I don't know how to explain it, but this is very weird kind of presentation that we are getting nowadays. Yeah.
So even when we were
is it a boy or a girl?
Girl. Why?
No, just because Fanconi's anemia without anemia will be very rare. If it was a boy, I would have thought of Wiskott-Eldridge syndrome with thrombocytopenia immunodeficiency. That's it.
Yeah, but we read about that, and for years, initial years, they may have only thrombocytopenia. The cell lines may fail gradually. So
she's
anemia
8
may
year
come
old, isn't
later.
it?
She's 7 years, yeah, and they may develop in the next 1 or 2 years. They may develop anemia.
Okay.
We did not do we were planning to do the chromosomal breakage and all those things, But unfortunately, the family got so, with this all tuberculoma, and then telling a second diagnosis also, they were literally very shattered. So as of now, we're just waiting for her to come out of all this, and then we'll be working her up for a Fanconi as well. But there is a strong suspicion of Fanconi anemia. Yeah, please.
Kavita, I would recommend you do the spinal imaging as well. If you haven't done it, you probably have. The few
We
cases
have done. Spinal screening was normal.
completely.
We have done only screening.
Yeah, that should be okay. Except that the few infections, particularly TB, we saw from South America as well, and from some of the centers in Mumbai, particularly with our initial COVID collection. Yeah, the TB was presenting in a very malignant fashion, very aggressively, as you can see here, lots of tumefactive kind of process going on. And till date, nobody has been able to put it together in terms of what synergism happens between organisms. And they seem to be not having fevers, and the markers are not that raised, but actually the morbidities and the mortality has been quite high with those children. So please let us know how this fares and whether this is going to be drug resistant or something more standard.
Sure. Thank you.
Okay, thank you. Okay, say it again from Dr. Kavita. If one of the fellows
Sir,
is
am I
able to
audible?
speak. Yeah, please go.
Sir, am I audible? Hello?
Yeah, you're audible. Yeah.
Yes, sir. So this is a case of yes, sir. This is a case of 2.5-month-old baby born of non-consanguineous marriage with normal birth history. She came with the complaints of right focal seizures, which were unprovoked, tonic-clonic in nature, 2 episodes in the same day. So we admitted the child, and on examination there was a bilateral port vein stain. So we added this for our academic interest actually. And
So
this port vein stain is bilateral.
Okay. And the diagnosis is?
Involving the ophthalmic and maxillary region of the trigeminal nerve.
No, I was asking the diagnosis for the case, but anyway, I'll probably show the images first.
Yes.
Do you want to go ahead with the findings?
So
I have a question before you show us the finding, because we all know the diagnosis here. My question is, 2.5 months, was she not born with the bilateral port vein stains? She probably was, right?
Yes, sir. Yes, sir. She born with bilateral port vein stain.
And she's also got seizures going on whenever the seizures started. So even forget about the imaging, we know what it's going to show, but at what point of time from birth did you decide to do the scan? And why wouldn't you do an earlier scan to start early neuroprotection?
Yes, sir, but she came to us on the day of seizure actually. She was born somewhere else, and because of this port vein stain, parents have shown to many pediatricians and dermatologists also. They said it's just a birth normal skin lesions during the birth, and they will regress later.
And the reason I was provoking this question was because yesterday we had a similar discussion with Dr. Sarah Ellett, who does most of the SWS work here in UK. And she asked me as to what is the right time frame, because can we pick up the PL angiomas early? And the answer is yes, but they do need an MRI and they need contrast, and they probably need a flare contrast for that as well. But I think you have the answer on CT here as you were showing, so I'll let you proceed.
I have the CT and MR. So, Ramin, do you want to list out the findings?
It is showing effacement and
okay, probably I'll just do it from here. So there are some hyperdensities in the cortical regions on both sides. Calcification predominantly in the bilateral region, predominantly left frontal region.
Yes, sir.
And the MR, the flare, you can see the corpus, the choroid plexus is demonstrating some hyperplasia. There is some atrophic changes along the right frontal region in comparison to the left. Some areas of hypointensities in the left anterior periventricular region, possibly prominent medullary veins. Tortuosity of the cortical vessels, the superficial cortical vessels on both sides, and also along the lateral and posterior convexities. The gradient images demonstrated further calcifications along the right cerebral hemisphere and also in the left paracentral region. Post contrast, you can appreciate the extensive file angiomas on both sides. The coronal plexus are also demonstrating angiomas. I'm not sure if the ocular examination was done and if these are ocular abnormalities. The slightly thickened appearance on both sides and also demonstrating some degree of contrast and enhancement. No arterial abnormalities. The only question was I was not able to find any. I mean, are these cortical tortuosities common or not in Sturge-Weber syndrome? The rest of the imaging findings are possibly typically present, but the question was of the tortuosity of the vessels.
Extremely common, Nihaal, and grossly underreported. In fact, there are instances where I've not seen the obvious PL. It's not an angioma, actually, it's a misnomer. It's a veterinary malformation that you get on the surface of the brain. But there are cases where we don't see that, and we have just these prominent anomalous draining veins, which is also defined as a feature for Sturge-Weber syndrome. So it's extremely common, the anomalous venous drainage. In fact, in one of your pictures, you have the left frontal DVA, the developmental venous anomaly, goes with the entire spectrum of these problems that happens. Okay.
Also, they have a significant Sorry, Kish, sorry, you were telling something.
No. I'm just, in 2.5 months, there has been a very rapid degeneration of the brain here, isn't it? Very much.
Yeah, definitely. And do they start very early aspirin, or when you said the neuroprotection, what did you out of the this one?
So yeah, according to the neurologist here, I've asked them what exactly do they mean by neuroprotection, and they said aspirin. But of course, if they have seizures, then you might want to control those seizures, and you can see that on this T2 here, which Nihaal is showing below. There's already hypermyelination, accelerated myelination happening on the left compared to the right. So the seizures create the axonal degeneration that's happened from the profuse seizures has led to this atrophy that we are picking up as well. So perhaps early intervention would be key in many of these cases.
Other thing is, Cirrholimus is a very good drug actually in this sort of situation. The youngest stage we have tried is around 6 months of age. It reduces the seizures. It reduces the seizures and also improves the neurological outcome. The recurrent acute episodes, what they present with encephalopathy, hemiparesis, hypertension, is they present in acute episodes. So that actually we have had a significant control with Cirrholimus in 2 children. So I think that's another thing. Not sure as to at what age that can be started. There are no clear data on that.
That's worth publishing if you have had.
So even aspirin, even aspirin. I wanted to ask at such a young age, can we start that? I mean, I was really in 2 minds at 2.5 months. Dr. Lokesh, what is the youngest age? Okay.
Yeah, the data is not there, but people are starting to use very early once I see this. But as I said, Cirrholimus, we started at 6 months, but there are other vascular lesions. There are a lot of work on Cirrholimus and vascular abnormalities. Very young age as well, they have started. Not necessarily neurological, but other vascular abnormalities.
But here the problem is bilateral, and I'm not really foreseeing a good future for this child. I mean, there's no surgical option also later, even if we salvage him to a certain age. So that's going to be
I think we have actually, they can do reasonably well. We have children who are now 20 with bilateral asymmetric involvement. They're independent. Some of them develop either seizures or visual impairment, but they can have independent this one if you act aggressively. But it not be
presenting too early also.
Yeah. Presented very early in the
already atrophic brain. Okay.
Yeah.
Dr. Lokesh, start the Cirrholimus at the first episode of hemiparesis, or did you start on those kids who had 1 or 2 more?
Yeah, once they had a second episode, at that time we have started.
Second episode, okay, fine. Because I think Nihaal has one of my patients down the line, similar findings.
Yeah.
Dr. Goldhauser, what is your take on this? Sorry, Dr. Kshitij, you want to say?
No, I was just going to say that there are some guidelines that are emerging from the UK, which will be published in the archives. But if one of you drops me an email, I can connect you with Sarah Aylett, and she can probably give you an idea of what the emerging guidelines would be. And I think Cirrholimus will be a good discussion early.
Sure.
Definitely.
And thank you very much. Yeah.
So can I ask
Dr.
a
Voltas,
question?
or did you?
I know the literature from the UK. There are many. Every year there is a paper about new issues and new questions and about aspirin, but it finally, the paper ends by, we need more studies, there is no evidence. But I mean, it's not dangerous to give aspirin, but I'm not really believe it will make a great impact on the further course.
Okay, thank you so much. Brahmini, you wanted to ask something?
Finally, that pickup from
Yes,
Nihaal about the choroid.
Sir, I have seen the recent clinical trials of Sturge-Weber syndrome. They mentioned Cirrholimus and mTOR inhibitors are more for cognitive improvement. And they said cannabinoid for seizures, like refractory seizures.
Okay. For seizure, they mentioned lots of things, including ketogenic diet and all. Yeah.
It improves these acute episodes were significantly controlled. Actually, one infant who came in with almost 3 admissions in 4 months with these episodes, the episodes completely stopped in last 1.5 year follow-up after adding Cirrholimus. So it's not just for long-term cognitive outcome; it's beneficial in the preventing this acute decompensations as well.
Okay.
Because they're ultimately related to the ischemia, isn't it? Okay, thank you.
Okay, thank you. Dr. Magathi, you're saying something, or do you want me to go ahead?
Oh no, your pickup of the bilateral suspect choroidal angiomas is very important, because I think an ophthalmologist should be involved early with the risk of ophthalmos. You can already see there is a slight asymmetry, and the right side appears larger. So don't forget, in the midst of all the brain problems, the eye will become a big issue if this is not sorted early in terms of pressure.
Yeah, I checked with Brahmani.
No, that we have already.
We have called the patient. Yeah.
Okay.
In the first examination, the baby was not cooperative actually. So they given another appointment under local general anesthesia. They're going to do. They said clinically they are not as such ophthalmos, but they're going to do the intraocular pressure monitoring for glaucoma and all under general anesthesia.
Sure. Thanks.
Okay. Right. Thank you. Case 9 is from Dr. Ramesh. If Surbi is there, she can present it, or I can do it. Probably, I'll do it. The 6-month-old boy with global developmental delay presented with cerebral visual impairment, the lower limb more than upper limb weakness, left ankle and pronator contractures, had distal motor sensory axonal neuropathy pattern on the NCS. Birth history, was born to a third-degree consanguineous marriage, was a late preterm child with IUGR, had Klebsiella sepsis and had an episode of extubation failure. Mother had respiratory issues in the last trimester. We'll probably go to the clinical question after the images. Dr. Ramesh, you want to add anything to it?
No, that's all. Mainly the radiological.
Yeah. The child was scanned at another center, and here you have the axial T2 afflares. And you can appreciate that this is severe lateral ventriculomegaly. And if you appreciate over here in the left high parietal region, there is some loss of the cortex or cortical thinning with some areas of gliosis in comparison to the contralateral side. The ventricles are significantly dilated. Posterior fossa cerebellum is normal, at least on the axils, but you can see on the coronals there is a hypoplastic appearance of the cerebellum, and also the vermis is demonstrating some areas of atrophy and some signal changes, probably some T2 hyperintense signal changes. But in the aqueduct, if you see, there is, so these are not dedicated images, but I can appreciate that there is some areas of stenosis in the mid-aqueductal region. The corpus callosum is demonstrating secondary changes of the ventriculomegaly. I cannot appreciate any cortical malformations. Again, in the coronal images, you can appreciate the gliotic changes or the encephalomagnetic changes of the cortex, but no cortical malformations, no cerebellar cysts. generalized hypoplasia of the cerebellum and some degree of atrophy in the vermis. So the question was congenital muscular dystrophy or other malformations. I would think that both are not a possibility on the imaging. And these probably are changes of chronic hydrocephalus or chronic ventriculomegaly due to the obstruction at the aqueductal level. And if the gliotic changes are secondary to prior infections or not was the question, or prior hypoxic insults.
Yeah, whether all these changes can be explained by neonatal gram-negative sepsis and its complications alone, or is there something more?
Like to me, they can be explained very well, just like Nihaal has said. I think there is enough gliosis in that little rim of white matter that you see on the left side, on that coronal below, to tell us that there was extensive injury with relative sparing of the brainstem. That's why they're alive.
This vermis changes, is this secondary to fourth ventricular dilatation, or how do we explain that?
You mean the flattening of the vermis? Again, would you want?
Vermis signal change. There is some hyperintensity in the coronals. Is this an artifact?
No, it is real, but I'm thinking, is it gliotic changes because of the atrophy also?
Where is the hyperintensity on the coronals?
The T2, yeah, that
there.
one.
Yeah, there's a bit there, yeah.
And over here.
Anterior vermis, yeah. So what is your final diagnosis or suggestion?
No, we don't know. There is no obvious major malformation of cortical development, but because of the cerebellar hypoplasia bar atrophy, vermis signal changes, one thought was any congenital muscular dystrophy, because this child also has early contractures on one side.
So Ramesh, does your patient have preserved reflexes in the legs?
No, hyporeflexic.
Okay, and nerve conduction steady?
Axonal neuropathy.
So that cannot explain from the CNS, from the brain, right? Because that's what you are thinking, isn't it? Because that will not explain your brain alone cannot explain. So there is definite neuronopathy or a neuropathy, right? There is some form of anterior horn damage or a nerve damage, like you see in poliomyelitis. In an acquired disorder like poliomyelitis, where you can see a CNS involvement and an anterior horn cell involvement. So, is this? Sorry.
Sensory neuropathy also. Sensory.
So there is sensory involvement also. So that means there is no neuronopathy. So there has to be a neuropathic process. So because that cannot be explained by the brain at all. So your query is so valid. Like, how can this happen? So is there the child had some form, people have described neonatal GBS, sepsis associated with GBS, whether he had some form of a para-infectious neuropathic process along with the brain involvement. That's only what it can be explained by. Otherwise, it's so difficult to explain.
Right.
It would be very unusual to have a neonatal GPS, no? Are their immune systems so mature to even produce
yes. Like that? The neonatal GBS has been extensively reported. So it has been more CIDP actually, not even GBS. So there's a very good paper from Great Ormond Street itself, few years back, European Journal of Paediatric Neurology, 3 patients of CIDP from neonatal period. But I'm just trying to, one has to think of one illness only, some form of acquired illness which caused brain damage as well as nerve damage. So that's how it has to be, because there is nerve damage.
I think we'll follow up the baby for development, whether it's behaving like one-time injury versus any progression.
At least on the imaging, I wouldn't think it's related to congenital muscular dystrophy because many features are absent. And also the presence of the stenosis, if it's a chronically progressive or an acute hydrocephalus, and the injuries are post sequelae of an acquired injury, especially the left periventricular region. Also, the cerebellum also might have been affected. So that is pretty uncertain.
Yeah. I would agree. I don't think we need to...
Is the sensory involvement significant, Ramesh, or we are not sure? Is it more motor than one can even screen the spinal cord? That's one suggestion. There is significant sensory involvement on NCS.
But in a month-old, many times that can be technical also.
Yeah. So that's why maybe if it is just a motor form, motor involvement. So one has to see whether the NCS is technically incorrect. So if it is all normal, and if it is correct, whether sensory were done properly. So if sensory is normal, then it's all a motor involvement. So then a neuronopathy, like a spinal cord involvement, at the anterior horn cell junction, could also be considered. So one can look at gliosis in the anterior part of the spinal cord.
Okay. Sure.
That's just a suggestion.
Yeah, okay. Sure. We look into that. Thank you.
We'll skip these. Yeah. Case 10 is from Dr. Rashmi. It's a 3-month-old child, 24-day child, first born to non-consanguineous marriage. Both parents are in good health. Antenatally, the mother had less amount of water, was born full term by LSCS, died immediately after birth. Birth weight was 2 kgs, no NICU admission. Child had hernia surgery at 6 weeks in a peripheral hospital. Post-operatively, there were multiple generalized seizures and was started on levetiracetam. Child was first seen at the age of 9 weeks with concerns of excessive crying. On examination, had increased tone, no neck holding, looked emaciated and had failure to thrive with a weight of 2.15 kg. The EEG initially was normal with no epileptiform activity. CSF analysis was normal. PCR was sent and came positive for Klebsiella and received antibiotics for 2 weeks. Ultrasound abdomen and cranium was normal. Started on domperidone, esomeprazole, pacitane and Levipil. The review after a month, the child was gaining weight. I'm not sure the timeline of when the child was admitted to the PICU for hyperglycemia and metabolic acidosis. Dr. Rashmi, is it immediately after 1 month?
No. The child was gaining weight. The child was admitted with hyperglycemia and metabolic acidosis following the MRI scan, which was done on the 31st of December.
Okay.
So after sedation for MRI, the child didn't feed well and then was admitted. That was the time the child was admitted.
Okay. So clinically, you're thinking Klebsiella infection, but cause of seizures?
No, the Klebsiella. I'm not so sure because the protein CSF CSF was also done in a peripheral hospital only. The protein cell count, everything was normal, and they said PCR was Klebsiella, and they just treated it. I'm thinking clinically whether it is HI following the hernia surgery, but I did not want to say that peripheral hospital and all that, and I was not sure. That was what I was thinking because parents were very certain that before 6 weeks the child was absolutely fine.
And that can explain the seizures, multiple seizures.
Dr. Rashmi, just was there any exaggerated startle?
No, there was no exaggerated startle. There was a generalized increase in tone, truncal tone, and all the limbs tone, and there was severe failure to thrive. So when I was first seen only, I proposed NGT feeding. They were not willing for that. But anyway, with all the domperidone and all, the child gained weight in a couple of weeks. And
I was just thinking of hyperexplexia, early hernias, generalized increase in tone. That's why I asked.
I see. Okay, fine. Okay. Yeah. No, there was no evidence of hyperexplexia.
Okay. We'll probably continue the discussion after the imaging. So the scan was done at 3 months of age, Dr. Rashmi?
I've written. So the scan would have been probably done at 3 months and 15 days or something like that.
Okay. So you have the diffusion on top. Cannot find any signal changes on diffusion. No areas of cytotoxic edema. Nothing on the slightly degraded GR images, but no focal areas of hemorrhage or calcification. The flare images, there is some prominence of the lateral ventricles, the atria of the lateral ventricles. There's probably thinning of the corpus callosum, especially the splenium part, but at 3 months it is pretty difficult to say because it is not completely myelinated and developed. I cannot find any other abnormalities in the deep brain nuclei, no volume loss. Sagittal images, there's probably some thinning of the corpus callosum. No malformations. Coronal images again similar to the axials. Maybe slight degree of cerebellar volume loss, but not very significant. Nothing in the deep brain nuclei other than, and the posterior fossa structures also demonstrate normal volume. So on the imaging, at least I could say probably there's a slight degree of hypoplasia of the corpus callosum. Other than that, I cannot find anything else. So for a term child, and at 6 weeks, hypoxic injury, that would be pretty unusual, only to have hypoplasia of the corpus callosum without any gliosis evident in other regions. I'm not, the basic things are not clearly seen, but I cannot find anything else, at least on the films. If anyone wants to add anything to it.
Yeah, hypoxic injury was one of the differentials. We did discuss with them about genetic causes and all that. They were not willing to do any genetic testing. They said they will consider it, and we gave supportive care. I don't think this child will live. This child is not doing very well. Dad had called me up a couple of days ago. They've gone back to the peripheral hospital. Child is very, very sick, and he said most likely the child will not make it. So,
can I come back to history?
Yes.
Birth weight of 2 kilo at term is not appropriate. Do you have any idea about the head circumference and the length?
Head circumference was when I saw them at 9 weeks, the head circumference and the length were in proportion with the 2.15. I didn't think they were too small because I plotted it on the growth chart. But at birth, I don't have the head circumference.
But 2 kilo is too small for an Indian baby, is it, at term?
No, there are many babies. No. I have had 2 kilos, actually, when I was 2 kilos. Lot of babies are 2 kilos. Many of them do well. Many of them do have hypoglycemia also.
Yeah, I think what Dr. Bolsastre is trying to say is whether something has started in utero.
Yes.
To cause IUGR, and then episodic neurological worsening is happening following some surgical procedures or anesthesia. So any neuromuscular disorder or mitochondrial cytopathy that can have episodic worsening.
Yeah, I think that is a very strong possibility. Yeah.
Because both the times, I think following some sedation or anesthesia, there is worsening, isn't it?
You're absolutely right. Yeah. First time there was worsening following the anesthesia for the hernia. And the second time worsening was when the sedation was given for the MRI. Okay, that's helpful because at least we know that with the MRI, there is no hypoxic injury. So I can tell them that there is no hypoxic injury.
I would say that the imaging handle is pretty weak for this case.
Okay.
That is my conclusion.
Okay, fine.
But no definite changes of hypoxic injury. At least the hypoxia related change at 6 weeks post-birth.
We did basic metabolic testing, lactate, ammonia, and TMS. They're all normal. And LFT, lactate, ammonia, TMS, LFT. These are all normal.
Okay.
Congenital myasthenic syndromes are one of the differentials with what Ramesh highlighted, the episodic worsening, which can have this kind of presentation sometimes.
Would they have increased tone, Dr. Lokesh?
Oh, this child had increased tone. Okay.
Yeah, increased tone, yeah.
Okay, fine. Then probably not related.
Okay.
Did the child have any myotonia on EMG? Was any EMG done?
No, I did not do any nerve conduction study for this child.
Okay, we'll move on to the next case.
Okay, right. Thank you. Next case again from Dr. Rashmi. It's a 3-year-old 1-month child. It's the first child born to non-consanguineous marriage. There is previous history of abortion in the first trimester with a probable suspicion of fetal acardia. Child was a term child, normal delivery with 2.75 kgs at birth. no history of birth asphyxia. There were focal motor seizures at the age of 10 months. On examination, there was speech delay, normal tone, normal reflexes. There was a pink mark over the left side of the face. 2 episodes of seizures and 2 episodes of seizures controlled by carbazine, and EEG demonstrated right slowing in the right side. Child was admitted in January with a follow-up of a trivial head injury. There was no loss of consciousness. This was followed by an acute left-sided hemiparesis and was admitted to the ICU with anti-edema measures. Child had further seizures, which was started on levetiracetam. Anything to add, Dr. Rashmi?
Has just now been discharged, actually. So
Okay.
the child had further seizures, and after our discussion, I think I agreed with that. But then following that, the child had more seizures, so we had to start valproate and clobazam. So now the child, there's the hemiparesis sort of, after the second episode of seizure, the hemiparesis just recovered. The child started walking, completely walking. So it's probably one of those stroke-like events secondary to you'll be showing the MRI, isn't it?
Okay.
So discharge the child on aspirin, actually. So.
Okay. So we have external films, and as you have seen in the previous case with Dr. Kavita, these are the post-contrast images, and you have these pyeangiomas predominantly on the right cerebral hemisphere. These prominent transmedullary veins, as you can see over here, as a linear areas. I think the left side also, the temporal and occipital region also demonstrate the enhancement pattern, which is typical for the Sturge-Weber syndrome. I think these were initially reported as developmental venous anomalies. If you see on the coronal images, the top panel, the enhancement pattern is pretty typical. There is a DVA on the right frontal region, but along with the DVA, there are other changes which are pretty significant. The angio and veno, I cannot appreciate anything, but the contrast images are pretty specific for the diagnosis, and also a CT scan was done. And with the CT scan, you can appreciate this right frontal subcortical cortical glial calcification. Based on the imaging findings alone, we would think of Sturge-Weber syndrome as a possible diagnosis.
Yeah, that was very helpful discussion with you, Dr. Nihaal, the other day. Because the port wine stain is on the opposite side. So it's not a port wine stain, it's just a reddish stain which is on the opposite side. But obviously, I think Sturge-Weber syndrome is like a big spectrum of disorders with a lot of different things, right? So, and then on that basis only, I started them on aspirin to prevent further of these stroke-like episodes. And also a lot of anticonvulsants, but I'll hopefully wean them off one of them once we have a stable period.
Okay. So you would agree that this probably fits into the type 3 malformation, Sturge-Weber syndrome, without the facial nevus, if the dermatological change on the face are not typical of a port wine stain.
The facial nevus is on the opposite side. Usually
it's facial nevus.
That's not a nevus.
Okay.
Reddish discoloration, which is on the opposite side. Normally, Sturge-Weber port wine stain is on the same side as the lesion in the brain.
Yeah, but there are bilateral changes, but predominantly on the right side.
Okay, so right side there is nothing. The face is absolutely fine. Left side there is a reddish discoloration.
Okay.
Where is this pinkish? Is it on the front or on the cheek or whole face?
It's on the cheek, and it's a little bit on the eye as well. It's not on the full face, so it's not on the forehead, and it's not on the chin.
Yeah, so this is unusual. I mean, of course, there is, as you say, is a spectrum, but in Sturge-Weber, you usually have involvement of trigeminal 1 area, if I'm mistaken.
Yeah, you're right. I had a discussion with Dr. Nihaal about this case 3 days ago, and I did tell him that this doesn't fit into typical Sturge-Weber. It's probably, we call it Sturge-Weber, but probably there's a whole spectrum of disorders which have similar sort of clinical features with the seizures and the stroke-like events with trivial head injury, these sort of things. So the other thing is the brain EEG, we had slowing of the waves on the right side. And the slowing was there the first time round as well. 2 years back when the EEG was done, the slowing was there, suggesting that the right side of the brain is probably not developed properly also, right from the right from the very beginning. So is predisposed to having these sort of stroke-like events, which may be secondary. I was just reading the pathogenesis is very interesting. There is ischemia. There is some people, like Dr. Balchasa was saying, don't give aspirin. They say that it will burn out. They keep having events and it will just burn out. Whereas some people feel that it's better to give aspirin to prevent a further episode. Anyway, after a lot of thinking, I discharged them on aspirin, actually, a small dose of aspirin, 2 mg per kilo, along with all the anticonvulsants.
I was not saying don't give aspirin. I was saying there is no proven benefit, no double-blind studies. It's just a matter of belief, I think.
Right. Okay. Thank you again. We'll move on to our next case. It's from Dr. Vivek. Dr. Vivek, do you want to go ahead?
Okay, so this is a 7-month-old girl child who had an uneventful neonatal period. So she had a normal birth weight, a good weight. And as she grew, parents noted significant delay. She is cognitively like a 2-month-old baby. Motor-wise, maybe around just 4 months. Microcephalic, no visual connect. Hearing is normal. She has significant bilateral spasticity with pyramidal signs and intermittent truncal dystonia, and very irritable, just doesn't sleep. Parents actually brought her in for the irritability more than the delay.
Okay. But no neonatal abnormalities, I see. Okay.
So no neonatal concerns. So no asphyxia.
It's a term child?
It's a term child.
Okay.
And now significant failure to thrive. So just 5 kg at 7 months and microcephalic.
Okay. Here are the MR images. On top of the diffusion changes, no acute changes on the diffusion, but the axial T2 images demonstrate these areas of hypointensities along the subcortical region, the bilateral cerebral hemisphere, more along the right parietal region. There are areas of chronic ischemic injuries in the bilateral basic ganglia and thalami. Some areas of hypointensity in the caudate, probably old hemorrhage, and also on the T1 evated images, you can appreciate these hyperintensities along the bilateral deep nuclei, the periventricular region, and also the subcortical white matter. The cerebellum demonstrates asymmetrical appearance. There is some hypoplasia of the left cerebellar hemisphere in comparison to the right. The coronal images, again, you can appreciate the hypoplastic left cerebellar hemisphere. It is slightly the side thinning of the cortex in the left cerebellum. You can appreciate the hypointense change on the T2 weighted sequences. And on the SWI sequences, we have the expected areas of blooming corresponding to the T2 hypointensities. These can be probably hemorrhage or calcifications. And also the posterior fossa demonstrate these areas of foci of blooming on a suggest of probably old hemosiderin deposits. The additional finding for this case was this supracellular lesion, which had these T2 mixed iso to hyperintensities with a T1 iso to hyperintensity. It is fairly well circumscribed, no restricted diffusion, no abnormalities on the flare or the SWI. The optic nerves and at least the distal segments did not demonstrate any abnormality. There was these areas of blooming on the SWI in the bilateral optic nerves, whether these are calcifications or not, probably CT would have been helpful. So I'm thinking that the extensive parenchymal abnormalities are probably related to old ischemia or hemorrhage, considering there was no neonatal abnormality, no maternal abnormality or risk factors. Possibility of genetic disorders such as collagen vascular disorders probably needs to be evaluated. And the supracellular lesion, these are the differentials for the supracellular or cellular masses. And based on the imaging pattern, I would think optic pathway glioma or astrocytoma are the likely differential. If you see the pituitary gland itself is well spared, it's only a supracellular region along the optic pathway. So yeah, that is the hypothesis which I could come to. Is there any other suggestions?
Even the corpus callosum posterior part is also looking dysplastic?
It is thinned out. That is along with the process of overall gliosis or chronic ischemic changes, because the white matter itself is completely abnormal.
Okay.
There's volume loss of thalamus also. So these are all related to old injury. Whether the injury was an acquired injury or is it something with a genetic disorder causing this is the question. I don't think there's a relationship between the tumor and the parenchymal changes.
Yeah, it's just so odd to have two pathologies, a small baby, to have a tumor and a, So I'm just wondering if one could knit them together. But definitely call for to investigate for is important. The red reflex was there. The child didn't have a cataract, but that's something to look for. Any suggestions from others about this? So this lesion. So then one needs to do follow-up MRIs if this is a tumor.
Yeah.
So is it?
It is a tumor. I would think it's a tumor.
It's a tumor.
Yeah. Though contrast wasn't given, I'm pretty confident it's a tumor. Okay. Maybe you can get a contrast to the spectroscopy, but I would think it's a tumor. If biopsy is possible, then biopsy should be.
It's a tumor in the broad sense. It's not necessarily glioma. Could be also a, I don't know, a teratoma or a hamartoma or something like static. No?
Yeah. Just that the calcification hemorrhage wasn't there, but that doesn't rule out a germ cell tumor.
So a follow-up MRI and beta HCG and a few of those things could help. Yeah. Okay. Fine. Thank you.
Do you want to comment on the parenchymal changes? Given the negative history.
I think, as you said, Nihaal, this is very suggestive of collagen 4, 1A or 2. This is top on the list.
Would you consider ICARD?
Editorial lesion
clinically?
So yeah, ICARD and collagen, these were the clinical, especially with the irritability. So they're really irritable, ICARD babies. But there was no basal ganglia involvement, and it's very asymmetrical, the changes. So, but that can be there in ICARD.
But that can be there.
But,
it can be there.
Yeah.
Can we get a CSF neopen or?
I haven't done any tests in this baby. Families. So I wanted to just have one go. So because I know I won't have many chances with them. And the cerebellar atrophy, like cross diastasis, cerebellar atrophy on the left side.
Is probably related to an injury, given the hemosiderin deposits. So
that's why it will be odd for ICARD. Yeah, that will be odd for ICARD.
What about the calcifications?
The calcifications can be seen in call 4A1 and also Aicardi-Goutieres syndrome.
So maybe I need to search if call 4 might have tumor-like lesions. One has to just look for. Maybe there are any reports. So postnatally.
But I would think it would be coincidental rather than. I don't think there's any.
Right.
I don't think there's a.
Fine.
So it's a double trouble lesion. I don't think that.
Yeah.
Okay.
No, I was asking whether this child has calcifications. We have the calcifications.
I'm not sure. This can be hemosiderin or calcification. This is a GRE, so I don't have maybe a CT would be helpful, but
I'll do a CT when they come back. Yeah.
I'll do it. Okay.
Okay. Next case again from Dr. Vivek. Dr. Vivek, you can go ahead.
So probably this is again just for a discussion for follow-up, but I'll go through the history and I think the images will probably confirm the diagnosis. So he's a 10-year-old boy who has never had any history of any neurological illness before and came to me to the OPD with history of acute onset horizontal diplopia for 3 days, looking to the left predominantly, and his left sixth nerve was weak, just slight esotropia. And hyperemic disc, normal pupillary reaction, no fever, no encephalopathy. And after that, just because he had left sixth nerve and diplopia, we did a MRI brain. So 3 days history.
Okay. So the MR images, the diffusion is mild restricted diffusion, though I don't have a ADC. I'm not sure if there was restricted diffusion or not. But there are multifocal lesions. If you see on the flare, predominantly involving the white matter. Bilateral cerebral hemispheres, the subcortical, juxtacortical lesions are involved. The central white matter is involved. Periventricular lesions are involved. On the sagittals, you have these perpendicular lesions along the corpus callosum, the pericallosal lesions. Brainstem, there was a focal lesion in the medulla. Post-contrast study, we have a ring-like enhancement in the white matter, cerebral white matter lesions along the centrum semioval and the superficial white matter. Some areas of incomplete ring enhancement demonstrated along the juxtacortical lesions. No enhancement in the posterior fossa. This is the non-contrast images of the orbit and optic pathway. No edematous changes demonstrated, and post-contrast, I could not appreciate any enhancement. Probably there is some mild degree, but it is not clearly evident. The post-contrast sagittal, I'm not sure if these are enhancing foci. We don't have an axial, but if these are two lesions or not. So based on at least on the imaging findings, we think of a possible diagnosis of clinical isolated or irreversible syndrome going into multiple sclerosis. It has a typical pattern of appearance seen in multiple sclerosis, at least the parenchymal abnormalities. The spine was not seen, at least I don't have the images. The orbit also, I could not find any abnormality. But given the brain changes, I would think of multiple sclerosis related disorders.
So I had a query. So when we say MS, we say dissemination in space and time, right?
Yeah.
So space we have, we have because we have bilateral lesions. And time also we have because we have some contrast enhancing lesions and some lesions are not enhancing. So does a single MRI make you confirm or refute a diagnosis of MS?
No, I'm not refuting the diagnosis of MS. Yeah.
No, just asking. I'm just asking. Like, presence of,
I would probably still call it as an isolated syndrome and probably wait on the follow-up MRs, but pretty confident for getting the oligoneuclear bands positive for this case.
Okay, can I tell you the investigation results? We have done quite a few. Okay, so we did visual evoked potentials, which were significantly prolonged on the left side, but also on the right. We did CSF, routine showed 8 cells, 26 normal protein. Sugar was low, less than 50%, 40 as compared to 120. India ink was negative, cryptococcal negative in blood. CSF pressure was normal. So CSF oligoclonal band was significantly positive. So 4 to 10, and no band in blood. So oligoclonal is positive.
Any prior infections?
Okay, yes. So I forgot to mention, COVID antibody IgG was positive in this child in small chatters. He's not been vaccinated. He's a 10-year-old boy. So, but they don't give history of COVID, nor do the family members.
I was just asking because this just came out today, citing a strong correlation for Epstein-Barr virus causing MS. So out of 955 patients, they found only one patient without at least an antibody for Epstein-Barr virus.
But then this is antibody they did, right? So they have to check the common normal population also. We will be.
They did it for around 10 million people, but not randomized, not completely randomized. But just what they found was the 955 patients with MS had only the 954 had antibody for Epstein-Barr virus. So I don't know what's the correlation in India significance.
Okay.
The triggering factor for MS.
So there were two questions I had. One comment actually, and one is a question. I thought in this patient I'll have to repeat MRI after 3 months to confirm the diagnosis of dissemination in time, but I was wrong. One is the contrast and non-contrasting lesions that proves it, that it's dissemination in time, and CSF oligoclonal bands. So if you have CSF oligoclonal bands, that proves that there is dissemination in time. So that's something I learned from this patient, because I erred on the side for my previous patients where I would wait for 3 months in spite of oligoclonal bands. So even with a single MRI and CSF oligoclonal bands, you can prove it's not CIS and it's MS. The other question I have, once I start treatment, which we just started, could people guide how often people do MRIs, and how do you decide if the patient has responded or not? Is there a criteria, MRI criteria for them?
There is a criteria, Dr. Vivek. It was actually published this year itself or early last year. I'll probably send it to you. They have listed out the sequential imaging at 3, 6, 9 months and what sequences need to be done. Not all patients need contrast on the follow-up. The initial scans need follow-up, the brain and spine screening, but the follow-up scans don't require a contrast. They only rely on the diffusion and the flare sequences. So I'll probably send it out to you. Maybe you can have a better look. So it's an international MS guideline which came out, pediatric, especially for pediatric patients. Dr. Mankar was involved in the study, so I don't think he's here, but I'll just send it over to you.
He's sent to us also.
Yeah, I'll send it to you. Yeah.
And also send the PVL article, please. Cannot get it from JCN. So I've emailed you about it.
Sure, definitely. Yeah. I think we quickly go through one more scan. This was a 9-year female presented with seizures at the age of 3 years and also at the age of 8 years. No perinatal history, abnormal perinatal history. We just wanted to show the scans. The axial images, you can appreciate that the right cerebral hemisphere is completely malformed. There is polymicrogyria and also some degree of volume loss. If you see on the brain stem, is demonstrating Valerian degeneration, and also there is some hypoplasia of the ipsilateral cerebellar hemisphere. The left cerebral hemisphere, maybe the video will be better. So you can appreciate the extensive, though the image is slightly degraded, extensive malformed cortex on the right. Some asymmetry of the ventricles. So the left cerebral cortex is normal. There is asymmetry of the cerebral hemispheres. The right is smaller than the left. There is Valerian degeneration of the brainstem, and also probably of there's some hypoplasia, asymmetrical appearance of the cerebellum as compared to the contralateral side. So at this point, the question was, is it genetic or is it acquired? Probably ask Dr. Balthazar to comment on it, but I would think that involvement of a unilateral hemisphere with a Valerian degeneration would probably point out towards the diagnosis of an antenatal insult resulting in polymicrogyria.
I think this is likely acquired. This is not genetic. It's strictly unilateral, if I understand correctly. Usually the cerebellar hemispheres are symmetrical, but in terms of hierarchy, I think the main finding is the strictly unilateral situation in the brain. I would expect that this child has some mild hemiplegia, hemiplegic cerebral palsy on the left.
I'll check with the clinicians, doctor. But yeah, I would agree with you. It's probably an acquired insult resulting to these changes. Just the last case, it actually was discussed previously. Keerthi, if you're unmuted, quickly, couple of minutes.
Yes, sir. Yeah. Yes, sir. I think 2 sessions ago we had discussed this case, who had presented it to me at 1 year of age with predominantly motor delay. Predominantly motor delay initially, and after that till around 6 months of age, had motor delay initially, had attained decoding at 5 months, rollover at 7 months, and then there was slow motor regression. But cognitively, he was preserved, and there were significant pyramidal and extrapyramidal signs on examination. No hepatosplenomegaly, no excessive startles, or no excessive mongoloid spots. So the MRI we can discuss.
Yeah, actually, I discussed, I think, a couple of meetings back.
So yeah, I think the differentials kept were lysosomal storage disorder, is what I remember.
Yeah, okay. So you have these multifocal areas, more confluent areas of white matter abnormalities, also involving the basal ganglia. Some darkish appearance of the ventral thalami that probably in retrospect could be related to the hyperintense white matter causing these dark changes. But yeah, there is some degree of hypointensity in the ventral thalami. What was the age? 1 year.
1 year.
I think dentate change. Yeah, dentate changes are pretty normal for a 1 year child. Again, in the flares, you have these hyperintense changes involving predominantly the white matter and also the basal ganglia. Corpus callosum is thin. No diffusion changes. No significant changes in the T1s. SWA also did not demonstrate any calcification. I think hypomyelination, lysosomal, and probably thiamine-related disorders was the differences, Kirti?
Yes, sir. Yes, sir.
Yeah, okay. So
some sequencing was sent. Yeah.
Yeah.
So it has come pathogenic mutation for RNA-SCH2C. So phenotypically, actually, I went back and reviewed the natural history. Yeah, natural history is matching. They have initial motor delay, and then they can have it's subacute encephalopathy, so subacute progressive encephalopathy.
Okay. Anyone wants to comment on the changes? I think calcification and subcortical cysts would have been more specific on the imaging. But yeah, they can also present with these confluent lesions, as you have shown.
That's thank you so much. That's amazing. Like to have the differential with the genetic results, because now you think over and you feel that you have missed so many Aicardi Gutierrez because as a pediatric neurologist, I won't consider it in my mind as a differential higher up Aicardi Gutierrez, but this is great. Thank you.
Okay, if there are no further comments, that should be our last case. And I would like to thank everyone for joining on the festival day. And once again, wish everyone happy Sankranti. We'll see you again on 28th January.